Oh, Chini. Good evening, everyone. I hope I'm audible.
Yes.
I'm Dr. Sushmita Keerthi, consultant radiologist at Vijaya Diagnostic Center in Hyderabad. On behalf of Vijaya Diagnostic Center, I welcome you all to today's webinar. The topic for today's session is novel imaging insights on interstitial lung abnormalities and defining interstitial lung diseases. It's a very interesting topic because we routinely see it in our day-to-day practice, and we're often faced with diagnostic dilemmas, and we also have questions regarding follow-up. And to discuss this interesting topic, we have two eminent faculty with us today. I would first like to introduce our guest for today, Dr. Sudhir Prasad. Dr. Sudhir is a senior consultant in pulmonary medicine at Gleneagles Aware Hospital in Hyderabad. He completed his MBBS and MD from Osmania Medical College, and he's previously worked with the NHS in UK for 6 years. His achievements include Dr. S.N. Tripathi Memorial Oration at the Tuberculosis Association of India in 2020. He's also the Honorary General Secretary of the Tuberculosis Association of Telangana. Welcome you, sir. Our speaker for today is Dr. Kedarnath Dixit. Dr. Kedarnath Dixit works at Vijaya Diagnostic Center at Gulbarga. He completed his MBBS and MD from Karnataka. He initially worked as a senior resident at P.K. Das Institute and at CMC Vellore, following which he worked as an assistant professor at CMC Vellore for 2 years and as a consultant at Nagarcoil SP Scans for 3 years. I now request Dr. Sudhir to say a few words on the topic, following which Dr. Kedarnath will enlighten us on the topic. Dr. Sudhir? Dr. Sudhir? You're not audible. Dr. Sudhir is not audible. Sir, can you unmute yourself? Dr. Sudhir, you're not audible. Can you please unmute yourself? Or is it possible to rejoin? Dr. Kedarnath, are you able to hear me?
I'm able to hear you. I'm able to hear you.
Dr.
I'm
Sudhir,
unable to hear, sir.
Dr. Sudhir, can you reconnect? We are not able to hear you.
I think he's not. He's unable to hear us as well. We'll have to disconnect the session and reconnect it.
Sir is not able to hear us. Okay, so give us a few minutes. We'll just reconnect.
Shall we leave this video or are they going to connect it again?
Hello, Dr. Sudhir, am I audible now?
Yeah, you're audible.
No.
Yes,
Okay.
yes.
So did you hear me previously or not? No?
No.
Oh, okay. Okay. So actually, I was basically just introducing you to the audience and introducing Dr. Kedarnath to the audience.
Yeah.
Sir, so would you like to say a few words on the topic before Dr. Kedarnath enlightens us about it?
Okay. Yeah, interstitial lung disease is a very important topic because most of the cases are diagnosed very late in our country. Last few years, it has significant improvement has been there because awareness has increased, especially with COVID. A lot of CT scans have been done, and more ILD cases have been diagnosed now. So important that anybody with a chronic cough more than 3 weeks, 4 weeks, you suspect infections, but beyond that, a chronic cough of more than 2 months duration somebody with breathing difficulty, we should have a suspicion of an ILD, especially 50 or 60-year-old population. We should look for ILDs because these are fairly treatable if diagnosed early, and they have good survivors.
Yes, sir. Thank you, sir. Dr. Kedarnath, over to you.
So I'll start sharing my screen. Please let me know. Please confirm if it is there in the PowerPoint slide share mode. Is it there?
Yes.
Yeah. Yeah.
Yes.
Thank you. So good evening, everyone. Thank you, sir, and Vijaya Diagnostic for giving me this opportunity to present before you. An interesting topic, and it has been a novel topic which gives us an visibility of interstitial lung abnormalities. Although, as sir informed us that we are unable to detect interstitial lung disease in the early phases, so this is a pertinent topic wherein we are now dealing with interstitial lung abnormalities. Before the development of interstitial lung disease, are we able to pick up the findings and treat them well? So, proceeding with the topic. So there is no conflict of interest. We use copyright work for non-profit educational purposes directed towards making a contribution to the field of knowledge and creating sources of Vijaya Diagnostic Center, and it has recent papers on the which are related to radiographics, which has been published in 2021 and 22, as well as in the Korean Journal of Radiology. So the objectives of this today's study is to define the interstitial lung abnormalities, defining ILD and its classification, to see some of the classical cases of most common interstitial lung disease in day-to-day clinical practice, and also to prognosticate ILDs on HRCT. So we know that HRCT is the main play, and it plays a crucial role in the diagnosis and monitoring of fibrosing interstitial lung disease. It is based on the principle wherein there are n number of X-rays, which is helping out to have a 3D reconstruction. And we are able to get a thin collimation, and up to 1.1 mm of reconstruction is possible nowadays, so that we will be able to detect most of the earliest interstitial lung disease. Now, for accurate ILD diagnosis, CT images should be of high quality. The necessary conditions are thin section, which are preferably less than 1.5 mm and of high spatial resolution construction, and are required for optimal CT quality. The full inspiration of the images are needed most of the times, and expiratory scans can be done whenever you suspect air trapping, and which is a common feature in hypersensitive pneumonitis. Additional conditions to see for the cysts are MIP and MINIP images. MIP images helps to detect micronodules, and the MINIP images help us to detect hypoattenuating lesions like cysts and cysts. So for monitoring of fibrosing ILDs, followed with HRCT is indicated when there is a clinical suspicion of worsening fibrosis, and according to the ALARA principles. So let us define what is the pulmonary interstitium. Interstitium of a lung is a structural framework of lung through which courses the blood vessels and airways. It begins at the lung hilum and extends peripherally to the visceral pleura. The interstitium is divided into central peribronchosvascular interstitium, central lobular, peripheral or subpleural interstitium, and intralobular or parenchymal or alveolar interstitium. So based on the pathologies in each of the interstitium, we are able to classify and also prognosticate the interstitial lung diseases. Now, before proceeding to the interstitial lung disease, now we should know what are the interstitial opacities which we commonly come across even when the patient is asymptomatic. So, we all know that how are we diagnosing interstitial lung disease? We have a clear-cut diagnostic criteria wherein we know there should be honeycombing, there should be traction, bronchiectasis, and bronchiectasis. But in our clinical practice, we do not see come across oftenly those kind of findings. But we see some subtle non-specific findings like ground glass opacities and reticular opacities, and we are unable to make out whether it is an interstitial lung abnormality, whether it proceeds for an interstitial lung disease per se, or the patient will remain asymptomatic throughout his life. So recently in 2019, Fleischner position paper has come up, and it has tried to define interstitial lung abnormality, which is like an incidental finding, which is seen in which are non-dependent abnormalities that affect more than 5% of the cross-sectional area at of at least three lung zones on CT images. And although ILS previously were regarded as insignificant, they should now be included in the CT report of their potential clinical significance and its progression. So this is an idea wherein when we detect interstitial lung abnormalities, and you can see there is a area of pathway in ILD which coincides, and there is around 15 to 20% of the patients wherein an ILA progresses to ILD. So if we are able to detect these kind of patients earlier and we are able to treat them, we'll be able to prognosticate better, and at the same time, patient lives longer. Now, these are the most common imaging findings that you come across in the interstitial lung abnormalities. One is ground glass opacity. You can see the image A, wherein there are subpleural KZ opacities of undetermined significance. We do not know what is its value. Next, in image B, you can see that there are some areas of cystic changes, some reticulations of indeterminate significance. It can be due to post-infective inflammatory sequelae. And now another you can see some non-emphysematous cyst, which is in a single image. And the last one where you are able to see clear-cut stacks of cystic areas, which is similar to honeycombing. And these are the areas which are very definitive of fibrotic changes. Now, interstitial lung abnormality by definition is an incidental finding, or else it can be told as a patient might have come for some other screening. For example, patient would have come for a CT abdomen, and you incidentally pick up some reticulations, and you try to report. Now the patient goes there to the clinician, and clinician retrospectively goes back and asking for the symptoms, and if needed, necessary investigations. And if by chance if the patient is having similar symptoms like that of shortness of breath, of probably low grade, and also his PFT turns out to be abnormal, then the patient will be labeled as interstitial lung disease, maybe early or subclinical or early clinical interstitial lung disease. So until then, we'll have to label it as interstitial abnormalities. So this is a definition. By definition, we'll have to quantify how much percentage of interstitial abnormalities. If it is greater than 5%, then only you can label it as an interstitial abnormality. So in the first image, you can see that there are some kind of reticular opacities in the bilateral basal regions, which are also present in the bones. And you can see that by quantification, it is less than 5% of the lung parenchyma. So this need not be labeled as an interstitial abnormality. Instead, you can just leave it at that, and follow-up is not necessary. Only when you find out an interstitial abnormality greater than 5%, as you see in image E and F. So on quantification, it is around 10.6%. Then you are quite sure, and you need to manage it and follow up accordingly. So this is another image wherein we need to rule out pitfalls of interstitial abnormalities, because it is quite common in pulmonary edema, wherein you will see interstitial edema, and you are unable to differentiate each one of them. So you take a image which are in prone as well as in a full inspiration. You will be able to see whether there is cardiomegaly, and then rule out other things. For example, in this case, it is a poor inspiration in A and B, so that you can see some kind of wavy appearance of the vascular markings, as well as some ill-defined ground glass haziness. And the same patient, when he has a proper inspiration, full inspiration images, you can see that all of these ground glass densities, as well as the wavy appearance of pulmonary vasculature, is resolved, suggesting it is normal parenchyma. Another pitfall wherein you can still see scarring, pulmonary scarring, which is quite common in India. You'll be post-infective or inflammatory sequelae. You come across bronchiectasis. Generally, cystic bronchiectasis or varicose bronchiectasis is more common with infections, and if at all it is in the more of perihilar regions, it is central bronchiectasis is more common with that of infection. So we'll have to rule out incidental infections. For example, in this case of a Mycobacterium intracellular, which is in a 72-year-old female, we can see that there are some ground glass opacities and reticular markings, which anyhow are post-infective sequelae and need not be labeled as interstitial abnormality. This is another example wherein you can see the patient in the bilateral lower lobes, you can see some green bud nodules as well. Apart from that, you see reticular markings and mild pulmonary scarring. These are more along the peribronchovascular location and not in the subpleural location. So this can be probably secondary to chronic aspiration pneumonitis, which needs to be excluded and should not be labeled as interstitial abnormality. Similar that of osteophytes, which is very common. You can see that dorsal osteophytes causing of compression or length parenchyma, and there is some inflammation leading to related fibrosis in the posteromedial aspect of the right lobe. So ILD often shows progression on images with reported progression of 20% in 2 years and up to 73% in 5 years. So that is very important to detect in the early phase. Now ILA does not, as I earlier told you, it does not imply that there is symptoms. It can be asymptomatic as well. So once it goes into the multidisciplinary team, the ILA can be labeled as ILD. So until then, radiologists need not report it as ILD. So we can come on the same page while reporting, and we can have a unified reporting structure in future. And they are also attempting to provide IRADs like that of ORADs and BIRADs. This one, and they are able to even tell what is the categorization and severity of the fibrosis. So coming down, for an example, wherein a patient has an interstitial opacity in A and B, wherein after this is a B is an image of follow-up after 1 year. You can see that those images are still mildly progressing, meaning that it is not developed into honeycombing, there is no traction bronchiectasis. And these are the non-subpleural opacities, which are not qualifying for fibrosis. So this above stacked patient is uh, probably a non-subpleural and a non-fibrotic opacity, which generally have a better prognosis. So you might have to do a follow-up for these patients if they are symptomatic, or else leave it at that. The second patient, wherein you can see ground glass opacities which are progressing, you can see one kind of non-emphysematous cyst not qualifying for honeycombing, and then you can see some ground glass opacities and some reticular opacities which are progressing in the next, but still not developing into a traction bronchiectasis or bronchiectasis. These are early interstitial lung disease probably, which are progressive in nature. Maybe in next course of 2 to 3 years, you will be able to diagnose a frank fibrotic type of ILD. And the last one you can see wherein, although you can see the E and F images wherein you can see some plate-like atelectatic bands, parenchymal bands, and reticular opacities which are subpleural in origin. And after 2 years, you can see there is frank ground glass opacities with traction bronchiectasis, bronchiectasis, and some areas of honeycombing, suggestive of a frank ILD. So prior to Fleischner position paper, and heterogeneous terminology was used, like that of ILD in the early stage, early ILD, preclinical ILD, or subclinical ILD. These kind of terminology should not be encouraged by the radiologist per se. It should be ILD, early ILD, or preclinical ILD should be only denoted once a clinical manifestations are done and multidisciplinary team has taken the. Now, there is a categories of ILA which has been recently brought up in the Fleischner positional paper, wherein you have to see whether it is non-subpleural ILA or subpleural non-fibrotic ILA and a subpleural fibrotic ILA. Wherein the last category is of high clinical significance, and even if it is detected incidentally, needs to get into complete workup to rule out early interstitial lung disease. So this subcategorization in reporting is very much necessary by the radiologist. Whenever you term ILA or interstitial abnormality, you try to tell it whether it is categorizing into subpleural, non-fibrotic or fibrotic, or if non-subpleural, how it is. And please rule out associated infection, pulmonary scarring, and what are the pitfalls in diagnosing interstitial abnormality. The problem with the radiologist in recent papers is that we are a chest radiologist, non-chest radiologist tend to overdiagnose ILAs and name it at least 40 to 50% are not ILAs when a review of those images has been done. So, what is the plan for management of ILA? After identification of clinically significant ILD, those ILA are anyhow, if it is clinically significant, you can put them into ILD and accordingly you can manage and put follow-up. Now, for example, if it is not clinically significant, then you will have to divide those ILA into high risk and low risk. If high risk, uh, these are based on the risk factors. So there are some risk factors, clinical and radiological risk factors, which help you know if he has inhalation exposures, for example, radiation therapy or thoracic surgery. These are at high risk because of the injury. And if those high risks are there, then you will have to modify those risk categories. And the radiological risk factors are, as I had told, subpleural and fibrotic are highest risk factor, and non-fibrotic according to the symptoms. So based on that, we categorize into high risk group if one of the risk factors are present, and accordingly, um, if there is a high risk, then you have to reassess clinically at 3 to 12 months if and with pulmonary function test, and if you find that the pulmonary function test is abnormal, then follow-up CT is necessary. If not, if the patient is fine, please do an CT after 12 to 14. 12 to 24 months or 1 to 2 years, and then see if the findings are remaining stable or progressing. If progressing, you can put it as ILD, and if it is same, you need not have to follow it. So coming to the interstitial lung diseases, once it has been diagnosed with the interstitial lung disease, we know that there are multiple causes. So in this clinical scenario, we are dealing only with the idiopathic lung disease, which a known cause. The treatment is quite easier, that you can stop the exposure to it, and for example, if it is related to hypersensitive pneumonitis, you'll have to stop exposure to the antigen, drug, stop the drug, and then associate with some genetic diseases, and really associate with some of the syndromes like that of LAM, PLCH, and IgG4. So in idiopathic interstitial pneumonia, most commonly chronic fibrosis, the definition needs to be recently the definition has been modified, and we have to define according to the UIP, because why are they defining related to UIPs? UIP is poor prognostic indicator. Once you define it as a typical UIP, then the patient has to, it means that the patient has a poor prognosis, and probably the survival period for 5 to 10 years is good. And it is quite important to label it as according to the UIP, whether it is UIP, whether it is probable UIP, or indeterminate for UIP, and unrelated to UIP. This was the old classification, and this the newer classification is based on the fibrosing versus non-fibrosing ILDs. Now, in fibrosing, how you define an UIP is based on architectural dispersion, traction bronchiectasis, loss of lung volume, honeycombing, and whether these are progressive in nature, and there is a temporal changes in the honeycomb. So all these five things, if they are there, then it is a fibrosing NLD, ILD. And apart from that, there are a few ILDs which are not manifesting these kind of phenotypes. Those can be categorized further and treated accordingly. This is a pathogenesis. This is a brief inflammatory and non-inflammatory pathways, and importantly, repeated injury and aberrant wound report leads to fibroblastic foci and an intermittent trigger and chronic interstitial inflammation leads to NSIP and chronic hypertension. So relatively, NSIP and CHP have got a better prognosis, lesser risk of mortality. However, UIP has got a very poor prognosis. So, based on the extent, the radiologist will be able to determine what kind of a disease it is, and then able to categorize it, and importantly, determine the distribution and extent, whether it is basal, subdural, and what is the percentage of normal. Now, recently there are AI, artificial intelligence things which have come up, and quantify it better. And if a fibrosis is greater than 20%, invariably poor prognosis. So, the these are some examples of reticulations, uh, reticular opacities, linear opacities, which are thickened into lobular septa, and there is no honeycombing as such. So you can see which is predominantly in the subpleural location and in the upper. This is an example of a traction bronchiectasis manifestation and phenotype, where you can see there is the fibrosis surrounding it, and irregular bronchial and bronchular dilatation is seen, more in the subpleural location. These are indicators of fibrosis. So this is a stack of honeycombing in irregular reticulations with a cluster of thick walled cystic spaces, which are greater than 2 per row and generally around 3 to 5 mm in diameter, but they can go up to 25 mm. So again, radiologically we divide into microcystic and macrocystic. Macrocystic is a more progressive in nature, indicates much more advanced stage of disease. This is the ground glass opacity, and more in the, you can see in the arrowheads, more of basal and subdural location. And these are non-specific, and what happens, we have to again categorize these when you see it as subpleural, non-fibrotic, and then follow it up if it is incidentally found. These are consolidations generally see with chronic organizing pneumonia, which is a pattern of interstitial, but very well treated and response to treatment better. And we rarely we see nodules and cysts in the interstitial, and this is more commonly associated with syndromes, and more commonly with PLCH and LAM. And mosaic attenuation ear tracking is also important criteria. We have to see it on the expiration scans and confirm it, invariably associated with subacute and chronic hypersensitivity. So I had already discussed with you that fibrosis and signs of fibrosis, honeycombing, traction bronchiectasis, and one. The more as it progresses, the poorer is the prognosis, and we have to quantify. There are AI they are coming up which show greater than 20% of fibrosis, poor, and generally they even on treatment they tend to respond very poorly. So these are some examples of I most common phenotypic patterns like that of visual interstitial basal and subpleural predominance, and distribution is more often heterogeneous. And non-specific interstitial, there is basal subpleural predominance with sparing as well. Again, in NSIP, we have fibrotic and non-fibrotic or cellular variety. The cellular variety has a better prognosis, and there is a entity of subpleural sparing in NSIP. In fibrotic type of HSP, there is a random involvement, and there is a no clear-cut apicobasal gradient. It can involve both upper and lower limbs equally, and as central and peripheral parts of the limb as well. So another part which we commonly see in is fibrotic abnormalities, which are upper lobe dominance. They also we also see in the case of the ankylosing spondylitis or pulmonary. So these are just a few of the cases where I wanted to show you classical cases of an ILD. Wherein this is a clear-cut UIP pattern. You have to just diagnose it as UIP, typical UIP, and based on that, you have to tell that whether that is probable UIP when you don't see honeycombing and you see fibrosis. It's a probable UIP. And indeterminate for UIP is when you see alternate areas apart from fibrosis, like that of mosaic carcinoma, see ground glass or some other cysts, cavities. So they are going in for alternative diagnosis. And indeterminate for UIPs, wherein you don't see the clear-cut fibrotic changes as well as an alternative pathology changes, and you are still not sure. For example, an interstitial lung abnormality can fall into this category. On follow-up, it might be turning into a fibrotic lung disease. So these cases need a follow-up and sometimes may require a biopsy. So some of the cases. This is an NSIP case wherein you are seeing more of a ground glass opacity in the bilateral subpleural regions with clear-cut subpleural sparing, more of a subpleural type of NSIP. You don't see much of honeycomb or significant traction bronchial. This is a case of a cryptogenic organizing pneumonia wherein you see peripheral consolidations. You can see fibrotic opacity, parenchymal bands, a little bit of you don't see honeycombing and minimal traction bronchiectasis, which probably with treatment might resolve. Again, you don't see much of honeycombing, but there is extensive ground glass opacities and also traction bronchiectasis. This is a case of an acute interstitial pneumonia, extensive, and the patient was clear treated for ARDS, and you can also see pneumonia. He was on ventilator, and some ventilated related lung injury can be seen as a bronchiectasis in the bilateral non-dependent lower. Some other fibrotic lung diseases are like that of sarcoidosis. This is an example of sarcoidosis when you see bilateral hilar lymphadenopathy and irregular fibrotic opacities and mass-like consolidations. Uh, Sometimes in the later stages, you might not see lymphadenopathy, but only fibrosis, which is and you don't see honeycombing invariably in sarcoidosis. This is a chronic sarcoidosis, wherein there is not much of lymphadenopathy, but one sarcoidosis. You can see how ground glass opacity is in bilateral upper lobes, but the patient was not much symptomatic and turned out to be he was a chronic smoker and it was a respiratory bronchiolitis type of ILD. Generally, they are asymptomatic and even pulmonary function test won't reveal much. This is a case of a subacute hypersensitive pneumonitis where you can see air trapping and some irregular fibrotic bands. They can proceed with honeycombing at erratic places, and based on that, similar case of respiratory interstitial bronchiolitis with the case. Apart from that, there is also a DIP which is going on in the lower lobes. These are cystic type of interstitial lung disease, wherein you can see regular bizarre type of more common associated with pulmonary histiocytosis. These are thin walled cysts, like chemo with both the apical as well as CP angles, and clinically, classically associated with back. And there is also associated rheumatoid lung disease. Most of the times when connective tissue disorders are associated with interstitial lung disease, they tend to also involve the upper lobe in as part of honeycomb, wherein you generally see an idiopathic ILD only involving the lower lobe. And here you can see also necrotic, necrobiotic nodules. There is some and this of rheumatoid arthritis associated ILD, bilateral upper course. And then you can see in this case you can see dilated esophagus and more of thrombus of traction bronchitis. Still not much of honeycomb. Systemic sclerosis is more common associated with NSID. This is the case of interstitial pneumonia where a classical of pulmonary alveolar fold. So the key message is that you'll have to first diagnose interstitial abnormalities, label it, get into the proper MDT multidisciplinary pathway based on the clinical findings and as well as some investigations like that of EFT and diffusion lung of carbon monoxide. They will categorize it as an early ILD. And then if ILD, you have to see whether there is UIP. And once you see UIP, you'll have to grade it. How much is the disease burden? If it is greater than 20, it is most commonly poor prognosis. And there are some AI like calipers which help you tell the progression, and you can on and there are some indicators like that of pulmonary vascular residual PVRS score. Than 5%, it indicates poor prognosis. Even honeycomb greater than 20% indicates poor. So, from ILA, you have to detect the UIPs and then also predict the UIPs. And the radiologists are at the center stage to diagnose these cases because many cases can be asymptomatic at the early stages. Thank you.
Thank you, Dr. Kedarnath, for the great and highly informative talk. Dr. Sudhir, do you have any comments? Sir, can you unmute yourself? Unmute, we can't hear.
A very good illustration, Dr. Kedar.
Thank you.
Important is for the clinician to get maximum out of a radiologist, we have to give you history, the occupation of the patient, and especially now the surroundings of the patients, either at the workplace or where they live. Because most of the places there is pigeon infestation. A lot of the patients we see with hypersensitive pneumonitis. And initially they only present with symptoms, but clinical science and even radiologically, they take some time to manifest. So whichever patient we are sending for a CT scan, we have to be giving some information to you so that you can give us back required information. So the clinician and the radiologist have to be on the same page about what they are suspecting, and then you give us back the information saying that whether it's an ILD and in that whether it's an UIP pattern or an predominant downglassing suspecting to be hypersensitive pneumonitis or something like that. And most of the times, the second commonest is the connected to disease-related ILDs. In this, predominantly, patients have either one of the initially CTDs, but later on they tend to manifest with the lung involvement. But 20 to 30% of patients, first the lung is involved. Once we diagnose ILD, after a few years, they turn out to be CTD positive, either RA or other SLE or Sjogren's syndrome, systemic sclerosis. So I think always talking to the patient, taking history and then following them up. Routine practice, we say 1 year of a CT scan to see the progression. Is it the same or you said somewhere 24 months?
In case of interstitial lung abnormality, sir, if it is a patient with high risk, maybe he has some risk factors, but you don't see those fibrotic opacities as such. If, for example, patient had a subpleural fibrotic opacities like that of traction bronchiectasis, then he will be labeled as an ILD and he will be followed up according to the pulmonologist. But for example, patient doesn't have much of symptoms, but you know that there is some subpleural non-fibrotic opacities, then the patient needs to be followed up at 1 to 2 years according to the pulmonologist, according to the clinical scenarios. And then you can leave it at that if he doesn't have much symptoms or his pulmonary function test remains stable and he doesn't have any progression clinically as well.
Okay. I think there's a good interesting discussion by you for all the ILDs and the interstitial abnormalities. Thank you.
Thank
sir.
you.
Thank you,
Yeah,
sir.
I just checked. There are no questions from the audience. So thank you, Dr. Kedarnath, for the wonderful talk. And thank you, Dr. Sudhir, for your valuable time. So let us close this session now. Goodbye, everyone.
Thank you, sir. Thank you.